Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Health Workforce Needs Part 1, Workforce to Support Value-Based Care, and it was presented by Angela Beck, Margaret Langelier, Patricia Pittman, with special guest moderator Clese Erickson on November 16th, 2017.
Good afternoon, everyone. I'm excited to be with you all to kick off the first of our two webinars that will feature the collective work of the HWTAC-funded Health Workforce Research Centers. This meeting kind of builds off of an earlier presentation where all the centers came together in May to share their collective findings, not only with each other, but with other policy leaders and associations and others who are really interested in health workforce, so we could begin a dialogue amongst ourselves and use this information to continue to find common interests and to build on our research agenda. So I think this is an exciting opportunity to continue on that conversation with all of you listening in today, and we look forward to having you engage in a question and answer session at the end of this with the panelists. Before we kick it off to our first speaker, I wanted to also have an opportunity for you all to hear from Ed Salzberg, the former director of the National Center for Health Workforce Analysis, who was there when the Health Workforce Research Centers were initially established. And he's going to give us a little background on the centers and then also set up today's theme on emerging health workforce issues in value-based care. And then we will hear the three presentations, and in between each presentation we'll offer an opportunity for one clarifying question. And then at the end we'll really open it up to a broader opportunity for people to ask questions about the collective research agenda. And we can get started. But before we do that, I would like to turn it to have our brief remarks by Ed Salzberg.
Hi, this is Ed Salzberg. It's my pleasure today to introduce this two-part webinar from the Health Workforce Technical Assistance Center at the University of Albany. These two webinars will present findings of the work from the Health Workforce Research Centers. The Health Workforce Research Centers were originally established with funding from HWTAC and the National Center for Health Workforce Analysis between 2013 and 2015. The 6 Health Workforce Research Centers and 1 Technical Assistance Center strengthen the public's understanding of health workforce and inform the health workforce policy discussions at the national, state, and local level. Today we're going to hear from 3 presenters talking about the impact of value-based care on the health workforce. We should be clear from the start that while policymakers are a key audience, that they're not the only audience. Many other groups really need this information to inform their decision-making. This includes schools, educational programs that need to decide, do we need an additional program or school? It includes health professional associations who clearly have an interest in their professional association. It includes providers, hospitals, ambulatory care organizations that need to know if we will have enough of the right types of workers. And it includes prospective students who need to know whether it's a good decision to invest in the education and enter a particular profession. So the data and information that the research centers produce is really informing the nation with the goal of assuring that the nation has the right types of workers with the right skills in the right places. We know that there's real challenges going forward. There's going to be increasing need and demand for health workers and for health services. At the same time, our resources are constrained. The question of how the pressure between doing more and constraining costs will play out is unknown. The workforce centers help us understand what the future needs will be. We know that there's been tremendous change in the delivery system, a significant push for value-based care, played out through bundled payments, accountable care organizations, Medicare Advantage, significant changes in the financing and delivery. The key question in the workforce community is, what will this mean for the numbers and types of health workers we will need in the future? So today we're going to hear about value-based care, and on November 30th we're going to have a second webinar which is going to talk about healthcare jobs, training, and career pathways. That fits very well with today's presentation.
Hello, today I'd like to summarize a few findings of a qualitative study conducted by our center in 2016 that focuses on opportunities and barriers from a workforce perspective of integrating behavioral health and primary care services. First, I'd like to share a few details about our center. The Behavioral Health Workforce Research Center was established at the University of Michigan School of Public Health in 2015. We're part of the Health Workforce Research Center network sponsored by the Health Resources and Services Administration. Given our center's expertise, we're charged with studying workforce factors that impact delivery of mental health and substance use disorder prevention and treatment services. Given the nature of our work, we're jointly supported by HWTAC and the Substance Abuse and Mental Health Services Administration. Our center benefits from the expertise of a partner consortium representing organizations from several behavioral health disciplines and research colleagues. Those folks are listed here on this slide with their logos there. A wonderful group that contributes to the work plan of our center each year. We also have two key advisors to our center who guide the work that we do. So the study I'd like to share with you today involves team-based care and looking at organizations that implement this type of integrated care service delivery. We know that the literature shows some evidence of benefits to integrated care delivery models, including improved access to care, better patient outcomes, improved employee productivity and satisfaction, and lower readmission rates. What's less prominent in the literature are workforce factors that enable or inhibit integrated care models from being implemented. The purpose of this study was to look at different types of integrated care models currently in use and identify effects of implementation on the workforce. To do this, we selected 8 key informants from organizations currently engaged in integrated care delivery. They included clinical professionals and organizational leaders. Interview themes for this study included things like workforce composition, worker satisfaction, workforce development and training initiatives, and barriers and best practices for developing and implementing integrated care. And this presentation focuses on that last point of barriers and best practices. This is a summary of the 8 organizations that we included in our qualitative study. They were chosen because they represented different types of healthcare settings. They serve different populations in some cases, such as Veterans Affairs. They're geographically diverse across the country, and they employ different types of integrated care models. We grouped the qualitative data from this study into themes to try to identify the top 5 barriers to implementation of integrated care. These are the most frequently mentioned barriers. The first one had to do with the fact that clinicians often lack prior knowledge about how integrated care happens from a workforce perspective and a workflow perspective. It's not something that's generally known or taught among the workforce. This can lead to initial resistance in adopting this model, and you can see that this quote here from a study participant is reflecting the fact that their site is constantly recruiting and trying to get the right person that will work in an integrated care setting, but they're constantly dealing with identifying primary care providers that just kind of don't understand this model and how that is a barrier to trying to develop this workforce. Next, key informants often mention having too few providers, particularly behavioral health providers, to even form teams. So if you have a shortage of clinicians, developing a team-based care model is particularly challenging. Respondents also mentioned difficulties with things like record sharing, particularly for patients with substance use disorders. This was a barrier that prevented the workforce from providing services effectively. Administrative and workflow concerns were also commonly mentioned. So the field is really looking for some guidance on how to logistically implement integrated care. Concerns about things like how to develop a workflow model, or things like lack of physical space to even accommodate co-location were frequently reported. And finally, lack of financial support for integration and the billing and reimbursement obstacles are substantial in some cases. So folks were mentioning things like the reimbursement structure is not really built to value team-based care. There are policy gaps in insurance reimbursement, and specific things like some restrictions on billing for physical and mental health services on the same day. So these are all considerable barriers, but all of these respondents found ways to address these, and we're currently implementing an integrated care model. A few of the notable best practices were that it's important to get buy-in both from leadership and the providers from the beginning. So this idea of top-down directives to the workforce tend not to work well when trying to develop and implement an integrated care model. Providers also need some assistance in understanding their roles on these teams. So a system needs to be set up that feels fair and collaborative to everyone on the team rather than competitive and inequitable. It's important to be clear about the benefits to patients and providers. Respondents mentioned that when collaboration occurs, their staff reported that caseloads often felt easier to handle, patients have better access to the services they need, and they also responded better to treatment. So all of those are outcomes that your providers would be very much interested in and may help motivate them to engage in development of a team-based care system. Finally, study participants emphasized the need of in-house training. They felt that most providers are not being taught skills that they need to implement team-based or integrated care in their degree programs, so establishing effective training mechanisms are definitely needed. In conclusion, study findings suggest that workforce shortages are a concern for both primary care and behavioral health, so additional support for workforce pipelines would be helpful. Better integrated care is needed in academic curricula because most employers are reporting the need to spend substantial time training staff on the job. Organizations should encourage mechanisms that establish a culture of coordination. Buy-in and leadership from all partners is important from the beginning. Finally, a few of the barriers mentioned in this study, particularly around reimbursement policies and record-sharing rules, are important, but we're starting to see some policy change around these. So hopefully that will help facilitate integrated service delivery in the future. If you have questions about this study or would like more information about our center, please feel free to reach out to us at the website listed here or my email address. Thank you.
Thank you, Angela. That was a great presentation. We'll go ahead and turn it over to our next presenter, Margaret Langelier, and she's going to be talking about some research that she's done as a part of being a Health Workforce Research Center that focuses on the oral health workforce. And this study was published in Health Affairs in 2016 and has actually had the honor of being selected by Alan Weil as one of the editors' picks, one of 10 editors' picks. So I think it speaks to the importance of the work that's being done through these centers, and I look forward to hearing Margie's presentation.
Good afternoon. My name is Margaret Langelier, and I'm here to talk to you briefly about value-based care in oral health and the implications currently for dental hygienists. In recent years, there's been increasing evidence of the impacts of the move to value-based care in oral health. And some of this evidence includes things like an increasing emphasis on improving oral health literacy among the public and policymakers and other stakeholders in oral health. There's an increasing focus on prevention and early intervention in disease process. We're seeing efforts to integrate oral health services into primary care settings, especially pediatricians' offices. We're seeing greater efforts to integrate electronic dental and health records for patients. A movement towards consolidation into large group dental practices away from the solo practice model in dentistry that has traditionally been the way of delivering care. Increasing recognition of the importance of risk assessment to triage patients to the most appropriate level of care. Use of capable technologies such as teledentistry. Emerging evidence of the use of team-based models to deliver care, and an initiatives to move oral health workforce into the wider community. So these strategies for reducing oral disease burden have shifted from an emphasis on treatment of disease to a focus on prevention and management. And this shift has required engagement of an inclusive oral health care team, but especially dental hygienists. The impact of this shifting paradigm on the oral health workforce is some reconfiguration. We're seeing expansion of roles for existing workforce, things like expanded function dental assistants, public health dental hygiene, called many different things in many different states, independent practice, advanced dental therapists, dental hygiene therapists, new workforce models, including community dental health coordinators, dental therapists. We're also seeing efforts to engage professionals in medicine through interprofessional education in formative education, and then using oral health screening and assessment tools, some of which are available through Smiles for Life curriculum within their medical practices. There's also been a progression in scope of practice for both dental assistants and dental hygienists, which is resulting in a change in the perception of dental hygiene from being simply a dental extender to the dentist to now being a preventive oral health specialist. So, scope of practice for dental hygienists varies considerably by state. There are assorted models for public health supervision practice and many different definitions of what that practice constitutes. Permitted tasks and required supervision differ greatly by states, and these differences impact service delivery. Even though they seem to be nuances, they can have very essential impacts on how care is delivered. In 2001, HWTAC asked us to describe, as best we could, how advanced practice models were actually impacting access to care. And when we were given this project, we did some literature review and realized that there were no numerical measures to assess the impact of the variation in scope of practice for dental hygienists by state on oral health outcomes. So in 2001, the Center for Health Workforce Studies developed a numerical index which scored a number of variables about dental hygiene practice using weighted scores based on their impact on practice in public health settings. The DHPPI, the Dental Hygiene Professional Practice Index, was developed in 2001, and there was a scoring update which occurred in 2014. And in 2016, we developed a new index with revised variables and scoring. The DHPPI contains a number of variables grouped into one of four categories: regulations, supervision, tasks, and reimbursement. The numerical scoring for each of the variables ranged from 0 to 4. The composite scores for a state ranged from 0 or 1 to 100. The 2001 scores range from 10 in West Virginia to 97 in Colorado, which will give you a general idea of the variation in dental hygiene scope of practice. When those scores were updated in 2014, the range was still pretty significant. It was 18 in Alabama and 98 in Maine. When we did the 2014 analysis, we thought it important to confirm that the instrument that we were using, in fact, was measuring a valid concept. So we did exploratory and confirmatory factor analysis to confirm that component scores were all aspects of the overarching concept, which in this case was scope of practice. In 2001, we used the scores in correlation with oral health surveillance data from the BRFSS, and we found that scope of practice was positively but not significantly associated with the percent of the population in the state having their teeth cleaned by a dentist or a dental hygienist in the past year. We wanted to look at whether or not there were any changes after the scope of practice had progressed in 2014 on the impact on oral health outcomes. So in 2014, we used multi-level logistic modeling to again examine the question about whether dental hygiene scope of practice actually impacted oral health outcomes in the population. The finding was that more expansive scope of practice for dental hygienists in states was positively and significantly associated with having no teeth removed due to decay or disease among individuals in the states with higher scopes of practice. I encourage you to look at the journal article, which was published in December 2016 in Health Affairs, which will further describe the findings of that research. So one of the major outcomes of doing the scope of practice in 2014 was that we as analysts realized that the variables that were selected in 2001 to represent forward-thinking scope of practice for dental hygienists no longer accurately represented the practice of dental hygienists, simply because many states in 2014 had almost progressed to the maximum score, and we realized that scope of practice was affected by new technologies and new permissions that meant that there was much more expanded scope to practice in states than was being measured by the 2001 instrument. So we designed a new scope of practice index for 2016, which was accomplished by working with a focus group of dental hygienists and with other researchers who had previously worked within the scope of practice realm for dental hygienists. And we ended up retaining or modifying some variables, adding new variables. We decreased the number of variables overall in the dental hygiene measurement instrument. Scoring weights were redistributed, and new variables were added, such as the ability to practice dental hygiene therapy, the ability to use lasers, and also the ability to provide basic restorative tasks. Once again, we used factor analysis on the new scale, which again confirmed the integrity of the construct. As expected, because we were including emerging practice in the 2016 instrument versus commonly used practice, the scores were lower on the new index simply because many of these things were not yet adopted in states. Still, the range of scores was 7 in Mississippi to 86 in Maine. These histograms are simply provided to give you an idea of how state scores on the DHPPI distributed in 2001, 2014, and 2016. I caution you that these scores are not comparable. 2001 and 2014 certainly are, because the same instrument was used to arrive at the scores. 2016 represents the scores on the revised or the new index, but these scores are presented here simply to show you how practice is now progressing further towards the high score of 100, and that there is much more clustering in the mean score area, suggesting that scope of practice over the last 15 years has progressed. Some of the findings were that high-scoring states, Maine, Oregon, Washington, remained high-scoring in all 3 years, and other lower-scoring states, including Georgia, Mississippi, and North Carolina, remained low-scoring in all states. We note that scope of practice for dental hygienists changes generally incrementally, although there are some states that do a very large revamp of their dental hygiene practice, and so they progress rather quickly. So the conclusions and next steps. We believe that scope of practice is a very important consideration when designing workforce strategies to increase access to and utilization, especially of preventive oral health services. Placing dental hygienists in community settings and enabling service delivery with some autonomy within their professional competencies may in fact improve outcomes. Our research has suggested that. We are currently in the process of analyzing data to determine the impact of scope of practice on access to oral health services and outcomes for children, and early results suggest that there's more of an interaction effect rather than a direct effect of dental hygiene services on children's oral health outcomes. And we're also finding that there may be, in fact, a tipping point at which scope of practice expansion makes a significant difference relative to the oral health population.
Thank you, Margie. And now as we switch over to the next presentation, does anyone have any clarifying questions for Margie that you'd like to ask? And I remind you again, post them on the chat to all of the participants so that I can see, as well as our host. Okay, so next I'll introduce our last speaker in the 3-speaker series here today, and that'll be Patricia Pittman, who is known to many of you as Polly. She's the director of the GW Health Workforce Research Center and co-director of the GW Health Workforce Institute. She'll be presenting some findings from the GW Center that focus on how health workforce roles are evolving in community health centers and in hospital settings as a result of patient-centered medical home efforts, accountable care organizations, and more.
Good afternoon. My name is Patricia Pittman. I'm the director of the GW Health Workforce Research Center. Our focus as a center is on emerging health workforce topics, a broad area of research, and what I wanted to try to do today is cover summary of some of the main findings that we've had over the last several years. So what I want to cover is what we have been learning about 3 different things. First of all, what job changes are occurring, and our center has focused mostly on community health centers, that is primary care, and in particular the safety net, and hospitals. So we have not done any work in the area of long-term care or home care. We want to look at how those job changes are related to payment policies, such as primary care medical homes, ACOs and Medicaid expansion, and then, of course, some technology expansion, such as electronic health records. So how are the changes related to changes in the context, the policy context? And then lastly, how have those changes, to the extent that we've been able to look at this thus far, affected outcomes, whether they are at the process level, such as expanded roles, productivity, job substitution, or at the real outcome level of healthcare outcomes or cost. So again, these are primarily studies that we have done under the HRSA funding mechanism, and attempted to summarize, do a crosswalk to summarize and identify some of the themes that we're seeing. So at the level of primary care, the community health centers in particular, we have looked at changes occurring between 2007 and 2013. And the major observation is that there has been tremendous growth in the workforce vis-a-vis the patient population, as well as diversification. So in particular, we've seen the growth in terms of a ratio of staff to patients in community health centers has increased by just over 10%. The largest growth has occurred among allied health care. As some of you know, the Uniform Data System, which is our data source for community health centers, has categories of staff. All medical staff includes physicians, PAs, NPs, nurses, and what they call other health staff, which are primarily medical assistants and some IT staff. When we look at the medical staff, removing other health, it's about a 12% increase. Other health, which in this case actually refers to the allied, about 30%. Enabling staff, which includes outreach and community health workers, about 6.9%, and administrative staff, 3.6%. So interesting that the administrative side has not grown anywhere near as quickly as the clinical staff, and among the clinical staff, it's really the allied where most of the change has occurred, or most of the expansions occurred. We're also seeing dramatic increases in the mental health and the dental staff, which is obviously great news since there's a lot of research that shows that co-location of these services with primary care is a very good thing. There, oddly enough, seems to have been less of a growth in substance abuse staff, and that may be because of the classification. It could be that social workers are not appearing in that category, and we did see a very rapid increase in the hiring of social workers. In terms of the primary care providers themselves, we see a relative decline in the presence of physicians, about a 34% growth in physicians, while we saw about a 74% growth in NPs and PAs. Nurses grew about 43%, and MAs grew about 60%. Again, MAs are in this category called other medical. At the hospital level, we have also done some work. Across hospitals in the United States, there's an increase in the number of hospitals that actually have PAs and NPs as staff, about 55 to 63% when we look from 2010 to 14. One study that was actually not a study funded by HRSA, but that is relevant to this level of observation, is that there does seem to be enormous variation in the way hospitals are using these staff, particularly if you look at the number of privileges that they have in different clinical areas. That privileging does not seem to be associated with scope of practice. It's really just an organizational decision. So growth in the use of these professionals, but not necessarily a lot of knowledge in how to best take advantage of their presence. We see a pretty steady level of staffing across the country in terms of nurses per patient when we control for acuity. On the other hand, we see a slight decline in the support staff. So those include about 26 jobs, many of which are supportive nurses, sometimes of other allied professionals. But overall, we see a bit of a decline in the support staff. And interestingly, in a study we did last year and just got published in Nursing Outlook, we see somewhat of a contradictory trend that one might assume is substitution, where those who are at the highest level of education and wages within the support staff category are the ones that are dropping most precipitously, while those that are at the lowest level of wages and education seem to be climbing. So there seems to be that sort of inverse trend seems to be telling us a story about some substitution of lower skilled staff for higher skilled staff in hospitals. What do we know about how these changes in community health centers and hospitals are relating to policies? So we've done a series of studies that each try to isolate the effect of different policies. Some of them are quantitative. We've also done some exploratory qualitative studies to see what the perceptions of staff themselves are about how policies are impacting the configuration of the workforce. So first, with PCMHs, the primary care medical home, we found in community health centers a very strong association with increased hiring of NPs and PAs, in addition to some modest increase in their productivity associated with PCMH status. This was not the case for nurses and not the case for the enabling staff, in other words, the outreach and the community health worker type worker, which was somewhat surprising to us since we thought there might be, in addition, a PCMH effect on that side of the workforce. We've done a series of studies on electronic health records and how that has affected the workforce. Initial studies that were cross-sectional showed a decline in productivity with the EHR adoption. Subsequent studies that were longitudinal were able to identify what appears to be a dip in productivity that then rebounds after about 3 years. These studies are also finding that there's increased hiring of other medical staff, in other words, IT and medical assistants associated with EHR adoption, and in some of the qualitative work we've done with CHCs, we see expansion of roles both for MAs and for nurses associated with EHRs. The work we've done on ACOs has been both qualitative and quantitative. In particular, we've used the AHA survey of ACOs to try to understand how ACO hospitals that participate in ACOs may differ from those that are not involved in an ACO arrangement. Certainly, the qualitative studies suggest that there are major workforce changes happening around the hiring of care coordination, the changing role of nurses that are to become more proactive in their functions, both in the hospital and in primary care, as well as a few other specific new jobs that are emerging, such as physicians that specialize in long-term care facilities and community paramedics. Interestingly, the qualitative studies report that ACO leaders themselves say that this workforce transformation is very slow, in part because the economics of paying for these changes is not quite there. We also see in the HA data and in some data we've been using from Premier that the differences don't seem to be as apparent as some of the ACO leaders might suggest they are. In fact, in hospitals that participate in ACOs, we did not see higher levels of care coordination, for example, or of RN staffing or of NPs and PAs. In fact, they were slightly lower than hospitals that were not participating in ACOs. So there seems to be either a lag or possibly more rhetoric than reality in terms of these workforce transformations. But I think everyone would agree that to the extent that they're occurring very slowly. A recent study we did on the effect of Medicaid expansion and staffing in community health centers suggested that the effect was, when isolating this policy in particular and controlling for other kinds of changes, the effect was actually quite small. We did see greater employment of NPs and PAs, or what we call advanced practice providers, and of nurses in CHCs that were in Medicaid expansion states as compared to non-expansion states. We saw a greater increase in MAs, in particular in non-expansion states. And this was a differences in differences design that allowed us to look both longitudinally and sort of comparing the point of adoption of Medicaid expansion. We've also looked at policies related to NP scope of practice reform and how they've affected staffing of NPs as well as NP productivity in community health centers. And again, there the effects seem to be relatively modest, if at all. However, what was interesting about that study is that it does seem to be a factor in reducing the reliance or the availability, we don't know, but at any rate the presence of physicians. And it actually seemed to affect the hiring of PAs. And in our discussion about why that would possibly be the case. We did look at some vacancy data that the National Association of Community Health Centers, NAC, had put out, and noted that the shortages of NPs are far higher, about 3 times as high. Almost 60% of CHC report NP vacancies, whereas only about 18% report PA vacancies, suggesting that it may be, even when DHCs are interested in hiring more NPs as a result of their expanded scope of practice, that it may simply not be feasible, and that they may end up hiring PAs as a result rather than physicians. Although, again, this is just at the level of speculation based on sort of an interpretation of our findings. We're certainly not certain that that's the explanation. And again, we had no evidence of a relationship of scope of practice laws with privileging practices of hospitals with regard to NPs and PAs. So I guess I would conclude then with just a couple of reflections. I think that overall some of the work that we did on hospitals is suggesting that there could be a downskilling occurring, and that clearly could have an effect not just on those workers but also on nurses who may have an increased workload and certainly could be contributing to burnout, and that could in turn be contributing to worsening outcomes, particularly in the area of patient satisfaction. I certainly have observed that hospitals have a lot to learn about how to best use their NPs and PAs with regard to the privileging. In terms of primary care, it could be that the shortage of physicians is driving a huge increase also in NPs, but regardless, with the growth of retail and urgent care clinics, it does suggest that this issue of a potential NP shortage is something that we should be looking at in the future. And lastly, on the ACO studies, I think that it's clear that this is part of a very long-term shift, and that long-term shift will probably be a need of workforce planners and folks that are specialized in helping manage the change. So those are a few of our study results and some reflections on some policy-relevant issues that are emerging from the work that we're doing at GW. So thank you very much.
Thank you, Polly. So that is the end of our 3 formal presentations. Before we open up to general comments and questions, do any of you have any clarifying questions that you'd like to ask of our participants? I guess I'll go ahead and kick off the conversation with a question for all of our panelists, and that relates to the idea that is value-based care going to, are you optimistic that we'll continue to move towards value-based care and away from fee-for-service and volume-based care? And are you optimistic either way that the changes that you've been discussing will continue even without value-based care, or do you really think that's central to further move towards expanded roles such as we've been discussing today? And Angela, since I hate to put you on the spot, but since I think we'll just go in the order of our presentations, if that's okay.
Sure, no problem. Yeah, I am optimistic that there will be more progress in integrated and team-based care, as my presentation talked about. I think it's probably not a fit for every hospital or every setting to maybe move in that direction, but as incentives get better and some of the barriers to adopting these delivery models start to be addressed, I am hopeful that we'll see more of that as we move forward.
Margie, did you want to comment on that?
Yes, you know, in oral health, the demands for access to oral health services are really driving the need for value-based care, simply because there are so many populations that are in need of services and aren't receiving them. So I think that this drive has gained terrific momentum in the oral health arena. We're seeing lots of consolidation over the last 5 years in dental practices, growth in group general practices, specialty practices, community health centers increasingly providing oral health services. And we're seeing that the scope of practice is changing for dental hygienists, which is an indication that team-based care is really gaining momentum. The idea that a dental hygienist can now be the front door or the gateway to a dentist is very, very important in strategies to increase access.
Polly, did you want to comment?
Sure. I mean, in general, value-based care and sort of the push for delivery system transformations that involve more risk on the provider side are a rare area of bipartisan agreement, or at least they have been thus far. I think there were some rumblings this week, but so far as sort of the political consensus, that seems like a really important sort of phenomenon to note. It's rare, and if there is bipartisan support, many of the programs that CMS has been promoting in terms of value-based payment will continue. So I think on the provider side, and certainly on the third-party care side, there's a sense that this is moving forward and the learning should continue. The question is perhaps how do we accelerate it, especially in light of the study, actually, Cleese, that you led on ACOs that shows that the current payment arrangements may not be enough to really make change happen at a pace that is ideal in order for these organizations to be successful in assuming risk. And I think there have been some conversations recently about how to include sort of workforce incentives on the front end of payment policies that are really interesting. One example is in Washington, D.C., the new health home program out of Medicaid is actually paying for practices to hire a social worker or a community health worker up front, and then paying for the number of so-called touches to patients that have 3 or more chronic diseases. And that is a different payment model than sort of the waiting to the end to assess savings. And I think experimentation with those kinds of payment policies could be very interesting in the context of moving the workforce transformation forward more rapidly.
Thank you. So, Polly, I saw you typed in a question for Margie. Do you want to go ahead and ask it yourself, or you want me? I can read it out loud.
Sure. So, I mean, I think that the methodology of developing this professional practice index is really interesting, as you know and others know, I'm sure, that in the case of NPs, there's been sort of a scoring of scope of practice levels. It's usually at 3 different levels. And there's been some criticism of that because it's not nuanced enough and it doesn't include other things like payment policies. The PAs have struggled with this as well, but, you know, in thinking about social workers or pharmacists and other professions that are also psychologists also interested in reforming their scope of practice or professional practice, we should say, because it's more than just the regulatory side. I wondered whether you thought your approach was sort of replicable. Obviously, they would be different measures, but sort of how much work goes into this, and how hard is it to maintain it year to year, and is this something feasible, and is it something that we should all be thinking about for other professions as well?
So, Polly, this scope of practice scoring actually began with projects from HRSA that scored nurse practitioners, physician assistants, and certified nurse midwife scope of practice back in 2001. A man named Ed Zazinski, who had worked at HRSA, who had been a lead at HRSA, had created a very sort of simple scope of practice index for NPs in the 1990s. I think it was 1993, and they wanted it rescored. And we actually rescored that instrument, but created new ones for nurse practitioners, physician assistants, and certified nurse midwives. Dental hygiene followed those scorings. I would encourage you to go on to the National Center for Workforce Analysis, Health Workforce Analysis, because somewhere in their archive those studies exist. This is a very, very painstaking process. I think the thing about our scope of practice studies that differs from some of those that are now more popular is that there was a lot of nuance in the scoring instruments. There was probably around 60 variables that were scored in the original dental hygiene scope of practice. I think it's down now to about 40. And the same was true for the physician assistant and nurse practitioner scopes of practice that were originally developed. Unfortunately, because they require review in detail of all statute and regulation in a state each year, along with opinions of professional boards, dental boards, boards of medicine, et cetera. It's a very, very detailed and careful process requiring we actually probably read that legislation probably 3 or 4 times before we actually complete the instruments. So unfortunately, it's a rather expensive process. It's one that we have always wished we could have completed for or continued to update for the other professions, but unfortunately the funding has only been there for dental hygiene. Even developing a valid instrument, frankly. You know, one of the things that was very, very important to us when we first started this was that we did field work with over 100 dental hygienists, for instance, and we traveled the country and talked to certified nurse midwives, nurse practitioners, and physician assistants in many, many states. I can't even count the number of focus groups that we held to find out what they considered to be barriers and facilitators to practice in public health settings. So the process of creating the instrument was as tedious almost as actually scoring it and doing the work of the research.
Yeah, I mean, the irony is private payers and providers, particularly those that operate across state lines, so the major players nationally have to do this for themselves all the time. Mm-hmm. And they're all doing it without sharing what they're finding. It's, I mean, it's a problem that is created by our crazy licensure system at the state level, but you wonder whether there couldn't be some central repository that's almost automated, some kind of artificial intelligence that could do this, because there's so many, and maybe funded by some of the payers, because everybody's doing it and trying to get a handle on it, and yet at a national level, we can't even keep track of what's happening, much less guide it with evidence. It's just such a mess for all the professions.
Well, and not to belabor the fact, but there is so much that affects scope of practice, everything from Medicaid regulation, for instance. We have to look at that to understand the nuance in payment methodologies. It's very complex, so that makes the task all that much more difficult, and again, more nuanced.
Yeah, we need a Watson for professions. Practice laws.
And I think an equally complex issue is a question that was raised. I think we may have just a couple of minutes left to address it, is how, you know, we have a lot of changes taking place in the workforce. How do we educate our workforce on these new models of care and make sure that they're properly trained and educated on how to work together as teams? Angela, do you want to start?
Sure. I mean, there have been some resources that have come out nationally, certainly around things like competencies that have been proposed for integration into degree programs, for example. There are also some centers that provide resources for training and workforce development around integrated care. The HWTAC Center for Integrated Health Solutions comes to mind, for example. So, you know, I haven't seen anything in terms of uniformly endorsed best practice for how to do this, but I do think there are some resources and tools out there and are growing in terms of the number.
I think we've seen in some of the work that we've been doing at GW that a lot of places are sort of reinventing this wheel themselves and coming up with their own training programs and efforts. And Margaret or Polly, do you have any other answers from your studies that seem to be good highlights of how we can go about this?
I think that workforce learns from the environment in the sense that we are finding that opportunities arise in programs, et cetera, to use some of these new workforce models and the changes in scope of practice, but it's such a quickly altering environment that it's difficult even for providers to keep up with it. So, you know, we do our best to speak to educators and the professions themselves about, you know, their opportunities and the changes that are affecting them. But it's a very challenging task considering the number of health professions we have and their distribution in so many different places, trying to, you know, actually help them to understand the changing work environment.
And I guess I would just add that there's a whole body of work on change management and for incumbent health workers. I'm not talking about the education side, but for training on the job. And we did one study in particular on sort of the processes of managing workforce changes. We did case studies on KP and Montefiore, and I think one of the major takeaways is, at least for large health systems that have the ability to do this, the engagement of the frontline workers in this process of defining what the changes should be is absolutely essential, and that is hard work and is an iterative process, and it has to sort of begin at the top of an organization, and it really changes the way these organizations think about their HR function. You know, the old HR function of talent acquisition isn't enough. There really has to be sort of labor engagement at a different level. Otherwise, there's going to be a lot of unhappiness and big problems with turnover, burnout, and so on. So there are some success stories. There's a great report that KP put out of their Southern California division called Jobs of the Future that talked about the different committees that they've set up to sort of reimagine nursing and reimagine different kinds of functions in terms of the support staff. Turning receptionists into sort of patient advocates and things like that, because they don't need receptionists anymore. So all these changes, I think, are very, you know, they're very scary, and some of them mean getting paid less money and moving where you work, and these are real people's lives that we're talking about. So engaging workers and professionals in the change management process seems to be a really, really important part of those organizations that have been successful in transforming their workforce.
That's great. Well, we're now 1 minute over our time. I want to thank our presenters for giving us these great presentations and engaging in a conversation with us at the end, and our colleagues in Albany for helping us set this up. And we look forward to part 2, which will take place later this month, I believe on November 30th, the same time. And I think then we hopefully will have fewer technical difficulties. And then I also want to point you to, and it will feature Bianca Frogner, Aaron Freyer, and Susan Chapman. So please join us for that one. And in the meantime, feel free to view the report that we have put together that summarizes the over 66 studies that have been completed as a part of the first 3 years from our Health Workforce Research Centers. So thank you again, everyone, and look forward to talking to you again on November 30th.